It's always a pleasure for me to come to Halifax. I travel around the country a lot, seeing the health system from different angles, and it's always interesting out here because people are way friendlier than in other venues, so I don't expect too much bun throwing tonight. I'm essentially a policy wonk. For people who read me, you know that. So it's a particular pleasure to help the Public Policy Forum celebrate its 25th anniversary, because that's a group of policy wonks. And I want to also start by conveying my best wishes to them for the next 25 years, because I'm pretty sure they'll be around. We'll talk about Medicare in a second. Now, it's pretty fashionable these days to badmouth policymakers. They're not very popular. Everybody poo-poos government. Oh, isn't government terrible? They take all our money. They don't do anything. They're a bunch of lazy bums, etc. And paradoxically, the loudest critics are often people who are seeking public office. We see this especially in the race for the Republican leadership in the US. They hate government so much they want to be in charge of it. I'll leave that for people to analyze who are smarter than me. But essentially it's pretty demoralizing times in politics and in the leadership department. Personally, I believe that government matters. That makes me a little old-fashioned. And I think that instead of hollow rhetoric about dismantling government, we should be focusing on improving governance. That's what we need. We don't need empty words, we need practical gestures. Now, of course, these are tough economic times, so we have to worry about money, more so than usual. But I don't think the answer is cutting mindlessly. The current recession, I think, makes us have to be, I think, even smarter and more creative than we've been in the past, where we could get away with spending a lot and excusing it and saying, oh, there's lots of money in the pot. The answer today is to spend strategically. Focus on programs that have the greatest impact, that do the greatest good. And that's what I think government should be doing. Now, I write from all across the political spectrum, so I get criticized by everyone, which I take great pleasure in. So people say I'm too right-wing, others say I'm too left-wing. So it's good that I keep people guessing. I like to think of myself as fairly pragmatic and practical. But I think it's important to say that the free market has a role in our economy. So does business. Nonprofits have a role too, and they all have a role in healthcare. But none of them are a substitute for democratic institutions and for democratic programs. We need public policy. As much as we can get mad about it, we need it. Public policy should be an articulation of our collective values. And doing so is not easy. Politicians have an unenviable role, and their deputy ministers, assistant deputy ministers, even a less enviable role, because they do the dirty work in the back rooms. To do this stuff, it takes more than wishful thinking. It takes vision, it takes action, and it takes a pretty thick skin, because you're never going to please everyone. It's hard work, but it's essential work. It's really the cornerstone of democracy. That's what public policy is. Good public policy should ensure a modicum of equity and of fairness and justice. That's why we do it. And all those things across social classes, across age groups, and across regions, particularly in a big country like Canada. So good public policy, essentially, its job is to level the playing field. But beyond that, to enrich society as a whole. So that's my sort of philosophical introduction to the topic. Now I want to talk specifically about the topic of the night, the most iconic social program of all in Canada, Medicare. And it's interesting that the word Medicare doesn't appear in any legislation. It's a word that, I don't know exactly its origin, it got dreamed up somewhere, but it's just an informal term, it's not in the law. But that's an aside for someone who likes language. Now, Medicare is a program that everyone knows and everyone loves. It's a great Canadian thing. But at the same time, it's a program about which we know little. Again, there's an interesting paradox there. I find that Canadians, as much as they love their Medicare program, are shockingly ignorant about it. They don't know its history, don't really know its raison d'être, its functioning, and they don't think too much about its limitations. I just think it's often hear Medicare described as something that defines us as Canadians. I happen to think that's nonsense. I think it's a good social program, but let's not give it too much credit, and let's not build up the mythology too much. And that's what we know more than facts. We know a lot of mythology. And what we hear more than facts too is scaremongering. A lot of scaremongering about what Medicare can do, how it's going to bankrupt us, all this stuff. Medicare is unsustainable. That's become the catchphrase for our times. Hear that over and over again from people of all political stripes, from business, from labor. A whole bunch of people say that in different variations. It's almost become accepted wisdom to say that Medicare can't survive. It's just too expensive, it's too burdensome, it's too much trouble. There's all kinds of reasons that it shouldn't work. And I've heard them all many times. But in the short time I have tonight, I hope I can set you straight on these questions, because I don't believe all the Chicken Littles who say the sky's falling. I want you to leave here tonight convinced that Medicare is sustainable. And I'm not going to give you a rah-rah speech about it. I'm going to give you a pragmatic talk. I'm going to tell you it's sustainable, but only as sustainable as we want it to be. And it's only as sustainable as the effort we put into it to sustain it. And I'm not sure we're putting in the right kind of effort these days. Putting in a lot of money, but not a lot of effort, not a lot of thought. And when we talk about sustainability, I want you to realize that first and foremost, instead of talking about sustainability, money, all that, I think we have to think about what we want to sustain and why. And we don't ask those fundamental questions near often enough. Why do we have Medicare? Well, what's its purpose? Beyond, getting me seen in the emergency room tonight when I smash my foot in the middle of the night on my hotel bed. What's its real purpose? It has a deeper purpose. Now in Canada today, we have a pretty decent public insurance program. That's what Medicare is, it's insurance. It's a good foundation on which to build. But this insurance program, Medicare, is essentially funding a health system that has a lot of flaws. It's a health system that's expensive. It's not particularly efficient. Anybody who's been in ER knows that. It's not safe enough. About 24,000 people a year die in Canada of medical errors. And it's profoundly undemocratic. It's not a democratic system at all. The patient doesn't have a voice. They're almost an afterthought in the system. System's built around providers. Now, I want the system to be sustained, but I don't want 25 more years of that. I'm not sure about you guys, but I don't want more of the same. I don't want the status quo. I think it has to change. I want a health system that's patient-centered, that's innovative, and provides value for money. And I want an insurance program with those same characteristics. And I think that's what we should all strive for. So how do we get there? That's the big question for today and for our politicians in the future. Now, someone smarter than me said, if you want to know where you're going, you have to first understand where you've been. And I think that's key. Before discussing the future, we need to talk a bit about the past and about the present. So I'm currently writing a book about health reform. I'm lucky enough to have a fellowship from the Conference Board of Canada. And sorry, David, I think that's your competition, but had to mention them because they're giving me money to sit around and think, so that's nice of them. And so I'm writing this book and I'm doing research to build on stuff I've already written about. And one of the chapter that I've had the most fun researching and writing has been a chapter about the history of Medicare. I really got into this. I did way too much work on it for the 2,000 words I'm going to write on the topic. But I could talk about it for hours, the history of Medicare. It's quite fascinating. But I want to give you a very brief Coles Notes version. And people from the internet age don't know what Coles Notes are, but I see a few people with my same hair color, so those are the people laughing. And the other ones are scratching their ample hair. So what do Canadians know about Medicare's history? Pretty well it can be summarized in a sentence. Tommy Douglas was the father of Medicare. That's why he's the greatest Canadian who ever lived. That's fair enough. He did play a pivotal role in the creation of a public insurance plan. But I think we have to resist the temptation to make Tommy Douglas a deity. We have to dispense with this notion that Medicare's principles were carved on stone tablets by the hand of God, and they were retrieved from a burning bush by Reverend Douglas. That's the impression I get when I hear a lot of people speak. And he was a human being. He had his flaws and he had his good parts, but I don't think he would like the position he's in today, the way he's glorified. He started a pretty good program, but we had to move on. The Medicare system we have today didn't emerge magically from Tommy Douglas's brain. It emerged from a series of cultural values that evolved over long periods of time, centuries even, in Canada. And that evolution went along pretty well, and Tommy Douglas grabbed that at the right time and built it into a program. The problem is that the evolution stalled after that. It became almost too formalized, and we've kind of rested on our laurels for too long. So let's talk a bit about the history, about how these values came about. The first hospital in Canada was Hôtel Dieu in Quebec City. It was founded in 1639 by Franciscan monks. 3 years later, Jeanne Mance founded Hôtel Dieu in Montreal. It's about a block away from where I live today, interestingly enough. And it was operated by nuns, by hospitalist sisters. Now don't worry, I'm not going to go through every year from 1639 to the present. I'm going to skip ahead a few decades, if not centuries. Religious orders continued to operate hospitals in Canada well into the 1970s, until Medicare became really formalized. And Quebec was the last province to join Medicare in 1971, actually, not that long ago. But I'm talking about the religious history because it reminds us that our system is premised on the notion that healthcare is a charitable act. It's not a commercial enterprise. And that's really important. That distinguishes us from many other countries. And this history helps explain why, even to this day, there are very few for-profit healthcare institutions in Canada. You can count them on the fingers of one hand. We all have not-for-profit institutions. And it goes back to this history. It also helps explain why Canadians have almost a visceral fear of any commodification of health services, which again is the norm in many Western democracies. But this stuff is important to realize because it tells us that cultural context is important. You can't create a system without understanding the culture that it's going to operate in. And there's a lot of people who make that mistake. A lot of pundits of healthcare say, well, let's copy the French system. The French system was declared to be the best in the world by the World Health Organization. Why don't we just copy that here? Or why don't we copy the German system? I saw that in the National Post last week. German system's great, let's do it here. Or the Dutch system. But you can't transfer these things whole hog from one country to the next because you miss out the cultural reference points. They really won't work. You can, however, learn from what others do. You can adapt the lessons they've learned to your system and to your culture. And we don't do near enough of that. And I'll come back to that in a moment, but I want to talk a little bit more about history. The other aspect of Medicare that's important is to realize it has its roots in rural Canada. This grew out of a cooperative movement, an offshoot of that movement, and it grew out of the farming mentality. And that's not to diss Medicare. These are important cultural reference points again. So what happened? What's the farming mentality? Well, the farming mentality is when somebody needs a new barn, everybody joins in for a barn raising. They give of their time, and they're going to get the same benefit later on. These days we call that paying forward. That's the common term. Similarly, farmers will store grain in good times to get them through the droughts and the difficult times. They're wise about putting money aside for when they're going to need it in the future. A very smart way to think about healthcare. Now, this pooling of resources and the notion that you pay forward is really the guiding philosophy of Medicare. So is innate conservatism. And we forget that. We forget about these roots, but they're important for understanding the structure. Now, unfortunately, we've kind of lost these values. We don't articulate them very much anymore. We've given people instead this sense of entitlement, that you should have access to unlimited care at all times. And that's not what insurance is about. The way insurance works is you put money in so that you may need it someday, and you hope you'll never need it. We shouldn't want to spend all our healthcare dollars. We should hope that we never spend them. But we've have kind of a twisted attitude today. And Medicare can't work with that kind of attitude. But that's the philosophical stuff. Let me talk a bit about more practical issues. For a long time, medical care was pretty rudimentary. It's pretty sophisticated today, but the medical revolution has really only happened since the 1960s or 70s. If you needed doctor or hospital care, you scrounged and you paid for it. That's how life worked for time immemorial. Canadians were tough people, but they weren't healthy people. When World War I came along, almost 40% of men were actually deemed unfit to serve because they were in such poor physical condition. Those who did serve got their first taste of routine medical care, something they had never known in their lives. And when they returned to Canada, they had new expectations about how they should be treated. That was sort of the first rumblings of Medicare. And this was especially true because right after World War I, the great influenza struck, the worst pandemic in the history of the world. Killed almost 100 million people worldwide, the so-called Spanish flu. Although it didn't actually begin in Spain, that's a misnomer. In that era, the first Department of Health was created. We never had departments of health before that. Public health units sprung up everywhere to deal with the flu and other infectious diseases. Rudimentary health insurance plans were created too, because care became more costly. The first one started in industry, in business. In mining, miners would pool their money, $1 a month, and create a health plan for themselves. They'd hire a doctor on site. Those were the beginnings of our health system. Now, the Great Depression quashed a lot of these initiatives. There just wasn't any more money. Then came World War II, and Canada had the same problem again. There were too few soldiers fit to serve. We still weren't a very healthy country in the 1930s. But post-war again, there was a lot of young men, those who were lucky enough to come back alive. Many of them had disabilities, injuries from war, physical and mental. And they had new expectations about health care. That's when Medicare, as we know it today, really took shape, because of those expectations and because society was changing. There was a real exciting, it was an exciting time then, this desire to build a society that was more just and more fair, instead of the dog-eat-dog society that we had pre-war. Now, I'll spare you all the provincial history because it's very complex and repetitive, but suffice to say that Saskatchewan became the first to create a provincial insurance plan. There are all kinds of regional, city plans, etc., but Saskatchewan made it provincial for hospital care. Later, a few years later, they would extend that to physician care. And every province followed suit eventually. National Medicare was born, for all intents and purposes, in 1958. It was born when the federal government passed something called the Hospital Services Act. And, most importantly of all, Ottawa agreed to pay half of all costs of hospital care. That's what gave us a national Medicare program. A few years later, again, they would extend that same deal to physician care. So let me tell you a bit about 1958, when Medicare was born. I, of course, was not born then. I'm much younger than that. But some people in the room were born then. Maybe you remember 1958. It was the tail end of the baby boom. We had a very young country. The average age in Canada was 27. Life expectancy was 65, which is, by the way, why we have a retirement age of 65. Pensions, that's true. Pensions weren't designed for everyone. Pensions were supposed to be for the lucky few who survived a few more years, those who beat the odds. That's an interesting part of another debate we could have today. At the time, more than half the population still lived in rural areas. We're a pretty fundamental resource-based country. Healthcare was also pretty straightforward in 1958. The biggest killer, he says, getting over a cold, biggest killer was still infectious disease, by far. The vaccination era had not quite arrived. It would arrive a few years later. But at the time, physicians essentially treated minor ailments, or they sent you to the hospital, where other physicians would treat you until you died. Essentially, that was the reality. You went to hospital to give birth, to have surgery, or to die. Long-term survival after diagnosis of illnesses like cancer or heart disease was essentially an alien concept. When you got diagnosed for cancer in the 1950s, you pretty well had a tumor the size of a grapefruit and you didn't have long to live. It's very different today. There was acute care and there was nothing else. So we built a health system and a health insurance system to meet those needs. It was entirely appropriate at the time. It was a great idea. So let's fast forward to the Canada of 2012. We're an old country. The average age today is 47. Life expectancy is 82. More than 80% of the population is urban. Healthcare delivery today is dizzyingly complex. It can't be done by a family doctor alone anymore. We need teams. Cancer and heart disease account for about 70% of all deaths. But people don't die quickly anymore. People live a long time after their diagnoses. 5-year survival rates for most major cancers exceed 80%. That makes cancer a chronic disease. 10, 15, 20-year survival is not uncommon at all for the biggest killer. Today, the vast majority of healthcare is for the maintenance of patients with chronic illnesses: diabetes, heart failure, COPD, arthritis, cancer. 7 chronic diseases account for 70% of all healthcare costs. Acute care still happens, but it's an afterthought today. It's very different from our old health system. So if you want me to summarize what's wrong with Medicare today, all you have to do is contrast 1958 to today. We're essentially trying to deliver 21st century care with a 1950s system. And we're trying to insure a population of chronically ill citizens with an acute care insurance scheme. It just doesn't work. It's fundamentally flawed. That's why we have long waits for care. That's why we spend too much on healthcare delivery. It's why our system's creaky. And I'm not talking just about our hospitals, which are run down, mostly in Eastern Canada. And it's why it's undemocratic. There wasn't any democracy in healthcare in the 1950s. As Dorothy said in The Wizard of Oz, Toto, we're not in Kansas anymore, but we pretend we're in Kansas. We're not in 1950s Saskatchewan anymore either. We need to drag Medicare, kicking and screaming, into the 21st century. That's really the challenge we have if we want it to survive another 25 years. Now, I've been skipping around in time a lot, sort of like an episode of Lost. So maybe you're wondering, what happened between the 1950s and today? And I'm tempted to say we built this secret underground vault, etc., but Lost is no longer on the air, so I won't go there. But a lot happened between the creation of Medicare formally and today. And a lot of good things happened, and we can't forget that. There's a lot of good in our system. We have a world-class health system. We have some of the best providers in the world. They're recruited from everywhere because we have really good medical education. We created a pretty good universal health insurance program. It exists in every province and territory. Regardless of income of people, they get cared for. There are 33 million Canadians who have free health insurance. And I use the word free here in quotes, because of course it's not free. But we all have access to really good care. It's an equitable system, and that's a good thing. When we discuss reform, when we discuss the future, we have to remember that. We have to remember there's a lot of good things that we can build on. We have to be careful not to throw the baby out with the bathwater. And I'm troubled when I hear that. I hear a lot of people say, we got to tear it down and start over. We have a good foundation. We just have to do some renovations in the house. We don't have to tear it down and start anew. The problems we do have are largely structural, and they're all fixable. And we can't forget that either. We kind of despair a lot when we talk about the future of healthcare, but it's all fixable. And there's a lot of stuff going on today. I'm actually very encouraged, which is unusual for a journalist, I know, to be pretty positive, but I'm encouraged by all the stuff that's going on. I think we're really ready to take the next big steps. But we have to change our mindset. We have to change our philosophy. I find that we've clung pretty pathetically to our 1950s approaches. And the reason we've done so is, unfortunately, because of public policy failures. This reluctance to step out of our comfort zone, a reluctance to innovate. And that's what we have to really do today. Now, the most iconic law we have in Canada, aside from the Constitution, is the Canada Health Act. And probably some people are wondering, when is he going to talk about the Canada Health Act? Well, it's time. Now, this is a law that was passed in 1984, unanimously by all parties in Parliament, one of the few laws ever passed unanimously. It was a law that was well-intentioned and a law that served pretty well its immediate purpose. And its purpose was actually to end the practice of extra billing by doctors. This was a big crisis in the early 80s. In Ontario and Quebec especially, there were doctors' strikes, there was extra billing. It was a big political problem. And the legislation was political. It wasn't a healthcare legislation. Now, over time, the CHA, the Canada Health Act, has also become an albatross. I think it's become one of the biggest impediments to health reform. Not because of what it says, but because we've conferred it with all these magical powers that it actually doesn't have. Now, as I said a minute ago, the law was drafted to stop extra billing. A political problem, not a healthcare problem. But the health minister at the time, Monique Bégin, was very smart. She's still very smart, and she's still around, and she's still great. She used the opportunity, this political opportunity, to consolidate concepts that existed in various pieces of legislation. She consolidated them all into one document. And why did she do it? She did it for two reasons. One, to make it much more palatable, to ensure that other parties couldn't vote against it, even if they weren't against extra billing. And the Conservatives were not against extra billing, but they had to vote for this law because it had so many motherhood statements in it. It was brilliant politics. The other reason she did it was to get into writing that the way that we're going to have some semblance of a national system. And the way that government did that at the time was to say, we're going to give you money to the provinces. They've always given money, but they're going to give money with conditions. And this law articulated those conditions. Now, we've come to know those conditions as the 5 principles of Medicare. And I'm sure everybody knows what they are, because there's going to be a test afterwards. So if you don't remember, write them down. This is always a key question on the test. So the 5 are universality, accessibility, comprehensiveness, portability, and public administration. The motherhood chant of Medicare in Canada. There's a few missing in there, affordability, etc., but never mind. But again, those are not really principles. They're 5 preconditions for receiving federal health dollars, a way of ensuring a semblance of a national system. So that's an okay thing, but it's not the be-all and end-all. A lot of people misunderstand that law, deliberately and otherwise. For example, it's stated as fact by many smart people that the Canada Health Act outlaws private health care. That's not true. It outlaws actually nothing. It doesn't even outlaw extra billing. It just says if there's extra billing in a province, the province is going to get its hand smacked by the federal government. It's going to have money withheld. Now, in practice, the law isn't enforced anymore, so it becomes even more meaningless. What the Canada Health Act does state categorically, and this is really important, is that public health insurance covers only medically necessary care. And that's defined as hospital and physician services, as you'll recall, which is what healthcare was in 1958. Unfortunately, they weren't a little more imaginative, because that's not what healthcare was in 1984. And it's certainly not what healthcare is today. It's very different. In 2012, some hospital care and some physician care is medically necessary, but only some, not all. So are some prescription drugs, some home care, some rehab, some palliative care. Some of those things are essential, but they're not considered essential in our law. I think we need a 21st century definition of medically necessary care. And what is that definition? Well, it's care that's essential, meaning life-prolonging. We can't do everything, all the stuff that's nice but not necessary. It has to be effective, meaning it works. And a lot of our healthcare interventions are very nice, but they're not effective. They don't work. We shouldn't pay for them. And it should be cost-effective, meaning that if there's 2 or 3 possible interventions, we have to do the one, or Medicare has to cover the one that gives the most bang for the buck, not all of them. So that's a tough definition, but it's a necessary one. Medicare cannot be all things to all people at all times. That's not what it was designed to do, and that's not the way it's going to survive. It has to provide the essentials. So our challenge in the future is to simultaneously expand the areas that Medicare covers into things like drugs, and at the same time limit what's covered within each of those areas. So not cover all drugs, but cover essential drugs, essential medicine, essential hospital care. That's the key to sustainable public health insurance in the 21st century. Not easy, but doable. Many countries, I said probably most European countries have done it. There's no reason we can't do it. Now, Canadians are very proud of Medicare. I said earlier, a lot of people say it's what defines us as a country. Again, that's nonsense, but it sounds nice, especially during an election campaign. It allows you to avoid talking about real issues, to say you love Medicare. Everybody loves Medicare. The Conservatives, the Liberals, the NDP, even the Bloc Québécois loves Medicare, but only in Quebec. Because it's distinct there, I can assure you. Now, one of the reasons we're so proud of Medicare is because we think it's unique. We really think we invented this concept. Well, Germany had universal Medicare in 1887, so they're about a century or so ahead of us. But, small detail, that doesn't come into play either when we're getting all jingoistic and loving our country. The reality is that all Western democracies, and even an increasing number of middle-income countries, have universal health care. We're not unique in any way. Most of them have much more extensive universal health care programs than us, and almost every one of them has cheaper universal health care than us. And I'm not even going to talk about that stinking bad country that's right below us, the United States of America, because it's an outlier. It doesn't even have a health system, so we're not going to talk about it. Let's not bring it into the debate. Let's compare ourselves to other civilized countries that are democratic. And those are in Europe. And they all do a better job than us. And they're in Asia, and they're in Africa, and even some African countries do a better job of universal health care than us. And that's pretty sad. Now, there is one unique feature of our system, and it's this. Our system is bifurcated, which is a nice fancy word that means it's split into two distinct entities. Our public health insurance program covers 100% of hospital and physician services. And that's something that no other country in the world is stupid enough to do. And at the same time, our public insurance program covers only a fraction of other health services. Things like drugs. It covers about half of drug costs, about 1/3 of institutional care, and virtually zero dental care. Now, no other country in the world is stupid enough to do that either, because it's not a smart way to operate. Even giving basic dental care is a really good investment. A lot of bad health originates in the mouth, inflammation, etc. But that's just one example. Most public health insurance plans in the Western world cover about 70 to 80% of all health costs across the board, with some form of publicly regulated insurance. The other 30% is covered by private insurance, or people pay out of pocket. And interestingly enough, that's the same percentages in Canada. We have that 70-30 split too, but we have this bizarre bifurcation within that 70-30. Now, this doesn't mean that countries have a two-tiered system. That's a term that I'd love to banish from the Canadian lexicon. I don't know what two-tier means. I think it's an utterly meaningless term and an emotion-laden term. It means nothing. We have multi-tiers, as does every country in the world. It means nothing. What these countries have done that we need to do is made decisions about what's covered by public insurance and what's not. We do it without doing it. We do it in a backhanded fashion, non-decision decision-making, the worst kind of way to make a decision. The countries of Europe are a lot less hung up about who administers their insurance plans. Our law says they must be publicly administered. Many European countries have private insurance that's mandated, mandatory health insurance that you have to purchase, and then heavily regulated. It comes out to the same thing. It doesn't cost any more. In fact, it costs less, and they regulate business. They're also, in Europe, a lot less hung up about who delivers care. Public institutions, private business, whatever. What they care about, above all, is that everyone has adequate, affordable health coverage. They're much more focused on the bottom line rather than the means to the end. That's where our priorities should be as well. In Canada, we tie ourselves in knots over this so-called private-public debate. And again, it's a false debate. It's a false dichotomy. My experience having parents who had chronic illnesses for decades, in fact, of care, and talking to many patients and providers all over the country for the past 20 years, is that most people really don't care who delivers their care, to be honest. They care about the quality of the care and the accessibility. I don't care if it's private for-profit business, not-for-profits, individual contractors, state employees. It doesn't matter. When you're lying on the gurney, that stuff doesn't matter. What matters is the quality, the delivery of the care. And what's important from a government point of view is to properly regulate that, to ensure high quality and cost effectiveness. Again, we don't get this right in Canada. We over-regulate hospitals and physicians, and we under-regulate other sectors. It's really the Wild West. We have sort of the worst elements of the US system, and we have some of the best elements of the European system, but we don't have the right mix of the two. So I've talked about some of the strengths of Medicare and some of the weaknesses, but I haven't really addressed the fundamental question I'm supposed to tackle tonight, which is up there. Can Medicare survive another 25 years? So put another way, put in Canadian terms, is Medicare sustainable? Is it sustainable for another generation? I'd love to hear our politicians debate that one on TV, because most of the election debates are pretty tedious. But that would be a more interesting one. But I'll ask Steve Paikin if he can sneak in that question next time. So what does the word sustainable mean? Usually it's assumed to be an economic term. Can we afford public health insurance for another 25 years? So let's talk about money for a bit. But I want to stress that I don't think sustainability is all about money. But money is important. You can't have a health... I was meeting with some people before the talk, and we started talking about healthcare, and somebody said, oh, you can't talk about this without money. And they're right. So let's talk money. Last year, we spent just over $200 billion in healthcare, on healthcare in Canada. $200 billion with a B. That's $5,654 per person, per capita. But of course, that's not evenly distributed. Most of our healthcare needs are at the end of life. I wrote a story earlier this week talking about how about 2/3 of all our health costs are on 10% of people in any given year, and we're all going to be in that 10% eventually. So it's not an unfair or unreasonable thing, but it's an interesting way how the math works. And that's exactly why we have insurance. But anyhow, back to the spending. How do we spend the money? The biggest category is hospitals, 29% of spending, drugs, 16%, physicians, 14%, and you'll notice two of those top three are covered 100% by Medicare. Other institutions like nursing homes, long-term care, 10%. Public health, we only spend 6% of our budget on public health and prevention. Capital spending, fixing up our buildings, etc. Not surprising that we spend a little less than 5%, judging from the quality of our buildings. And administration, 3.1%. So all these people who tell me we have a hugely bureaucratic system, I don't know, 3% doesn't strike me as unreasonable. Most private sector businesses spend a lot more than that on administration. I could make a good argument that we don't spend near enough, or we don't manage our system well enough. But a discussion for another night, maybe at the management school across the street or something. Now, is that the right mix of spending? Probably not, but there's no magic formula. So let's look at how it's changed a bit. I want to look 25 years in the future, so let's look 25 years in the past. 1987. 1987, we spent $39.8 billion on healthcare. That's a lot less than $200 billion. For some of us, 25 years ago wasn't that long ago. I, in fact, started working at the Globe and Mail exactly 25 years ago. That's $1,542 per capita, about a quarter of what we spend now. That's only 25 years ago. And the breakdown of spending was a little bit different too. Hospitals, we spent a lot more, 41%. Physicians, 15%. Drugs were only 9% of spending. They've been the fastest growing category for a number of years. Other institutions, pretty flatlined, 10%. Capital, we've never spent much, 4%. Public health, same thing. We had a big boost in public health after SARS, so it used to be 4%. And administration, 2.4%. So if I was being a good journalist, I would take these figures and I would say, spending on bureaucracy has risen 50%. It's shock relative risk, or relative numbers. So 3.1 from 2.4 is 50%, but it's still not very much money. But that's an aside. What do these numbers tell us, these comparative numbers? They tell us that we're spending increasingly large amounts of money on services that, in our existing legislation, are not deemed to be medically necessary. That's an interesting message that the numbers are sending us. These are things that are not necessarily covered by public insurance. What does that mean practically? Well, it means that Medicare is becoming less relevant. That's the message from the numbers, but I don't think that's the message the public wants to hear. I think the public wants Medicare to be relevant in different ways. For example, to cover their drugs. The way that drug payments are made today in Canada really offends the notions of Medicare. We introduced Medicare because essentially people were losing their farms, they were being bankrupted paying for essential care. Today, in this province, in other provinces, people are losing their homes to pay for drugs. It's fundamentally wrong and inequitable, and we have to fix that. And that's one of the areas we have to tackle quickly. But it troubles me that Medicare is becoming less relevant. It's not meeting people's needs the way it should. And the law that we have, the way it stands, is actually an impediment to shifting how we spend, unfortunately, because of this outdated medically necessary definition. I think, and many policy experts think, that we can and should spend a lot less on hospitals, and probably less on physicians, or at least differently on physicians, if not less. And the result would be not so much big savings, but it would be much better care, more efficient care. But let me stick to the money issue for a couple more minutes. What happens if we take these numbers and we project them out 25 years? What do we get? Well, you know, we have a line that goes like this, and if we keep following it, it keeps going straight up. The trend has been, for as long as we've kept numbers, since the beginning of Medicare, that health spending has doubled every 10 years. So we've had Medicare for almost 60 years. It's doubled every decade. So if it continues along that way, if we don't have some radical rethinking, doing things differently, by 2037, 25 years hence, health spending will be roughly $1.2 trillion with a T. Imagine that, 1.2 trillion. That's a big number, but it's not necessarily unaffordable. It really depends on a whole bunch of other things, the size of the economy, what we spend elsewhere, etc. But what makes the trend worrisome is not that final number. It's that health spending has forever, as long as we've been keeping records, outpaced both inflation and economic growth, often by wide margins. That is not sustainable economically, regardless of where you stand on the political spectrum. That's not sustainable. The result is that health is gobbling up an increasingly large proportion of all public spending. Medicare, as it's structured today, is gluttonous. It's gluttonous of public funds. When ministers and deputy ministers sit around the table discussing policy, what they say is that healthcare eats everybody else's lunch. And that's the reality. It's not so much that health costs us a lot, it's increasingly preventing us from doing other things that are good for our health. Spending on healthcare, social services, public housing, things that really keep people healthy in the long term, as opposed to fixing them up, patching them up with sickness care later on. So we have to be a little more forward thinking with this kind of spending. And that's one of the reasons we have to shift spending. Not because we're cheap, not because we don't like people, but because it's going to be more fair in the end. And that's what Medicare is all about. It's about equity and fairness. So how do we rein in spending? Oh, I think my time's up. I better stop. So how do we do it? Well, we don't do it simply by slashing public health coverage and forcing people to buy services privately. That's not going to work. The reason it's not going to work, one is every Western democracy takes care of the poor somehow, even if the party in power has to hold their nose to do so. They do so, because otherwise they'll be in trouble, even with their constituency. So the poor are always going to be taken care of. The biggest beneficiaries of Medicare are actually the middle class and business. And we don't say that enough out loud either. Those are the big beneficiaries, and that's who should be speaking up for. They benefit from the distribution of these services. Now, people are going to have to buy some services privately, and we already do. 22 million Canadians already have private health insurance. Mostly it provides drugs, but it provides semi-private rooms, pays for your ambulance service, some of your home care, etc. We have a lot of private insurance. Again, it's not very well targeted. It's all over the place. So there's a role for private insurance. Always has been, always will be. Tommy Douglas was a big believer in private insurance to supplement, and he was correct. But we have to be mindful too that what really matters to individuals is total costs. What does that mean? Well, our total cost is what we pay in taxes to cover our Medicare. That's about 40% of our tax bill and rising, plus the premiums we pay for health insurance, plus the stuff we pay out of pocket, things like nursing homes. Our goal should be to control the total amount of health spending, not just the public portion. Public portion is important because it's about 70%, but it's not enough. We have to be trying to control the overall spending. So how do you do that? Well, the most important and most efficient way to do it is to bring in more health efficiencies, more spending efficiencies. There's 1,001 ways to be more efficient. There's a lot of inefficiencies in our system, but there is no one magic bullet, and we should stop looking for that. We should just be doing a whole bunch of things, big and small, and things that we're already doing, but we need to ramp them up to a larger scale. We don't have a near enough sharing of ideas and near enough scaling up of good programs. So number one cost in healthcare is by far labor. About 2/3 of healthcare dollars go to pay health professionals. Again, not inappropriate at all. It should be a hands-on business to help people. But we need to get the right people delivering the right care. In other words, get everyone working to their full scope of practice. Right now, physicians do way too much stuff that other people can do. They should be focusing much more on medicine. And I think we'd all be better off for it, and so would physicians. It won't be a lot cheaper, but it'd be a little bit cheaper, but it'd be more efficient. Cooperation is essential if we're going to have cost containment. Just one example, provinces should be bulk buying their drugs across provincial borders. It's crazy that we have 17 bulk buying drug programs around the country because the federal government has several on its own. That's no reason that still exists today. Specialization. We need to focus. In the Drummond report in Ontario last week, 2 weeks ago, he said the era of the general hospital is over. Every hospital should be specialized. And I think he's right. We don't have to do heart surgery and radiation treatment in every single hospital. We have to do them in different areas and make it easier for people to get there and they become safer as a result. Volume brings safety. Coordination. Every patient needs to have a medical home, an entry point into the health system, and someone to coordinate their care, because care really is complex. Today in our health system, we don't have a front door. The front door is a default front door. It's the emergency room. It's the absolute worst place to start off the care journey. And unfortunately, that's how it is. And it's a starting point for a system that's disjointed. We have to make chronic care the focus, not acute care. We have to sort of turn the model on its head. And not overnight. You have to do it gradually. You have to gradually get people into the community. And that's the last big important point. We have to care for people where they live and not in expensive germ-infested institutions. And that's what hospitals are. And that's not to criticize them, but they're full of sick people. It's not the place you want to be. And way too many Canadians actually live in hospitals. There's about 10,000 Canadians today who are living in hospitals, meaning they've been there for more than 100 days because we don't know where to put them. And that's crazy. That's a waste of $150 million a day. So if you want to talk about savings, there's a lot of big savings to be had out there. But as I said before, I don't want this discussion to be just about money. Sustainability is also about sustaining our values. And again, we get a little squeamish about words like values. They almost sound religious, but they're not. They're really important. The question I'm supposed to be answering tonight is, can Medicare survive another 25 years? But I think it's just as important that we ask ourselves, how has Medicare survived 60 years already? Well, despite all the challenges, despite the doubt, Medicare has survived because of common values, through sheer force of will, public will. And again, we don't give ourselves enough credit for having kept this program alive. We need to remember why we created Medicare in the first place and why it's still needed today. And it's to be fair, to spread the burden when people do have a burden when they're sick. The purpose is to pool our resources. to ensure we'll all have essential care when we need it. In 25 years, that will be as necessary as it is today. It'll probably be even more necessary because providing care isn't getting cheaper or easier. So yes, I think Medicare can survive another 25 years. I would go so far as to say it must survive. It's one of the fundamental values we have, and we should defend it in every way we can. Our challenge is to allow Medicare to do so, to allow it to survive and to thrive. Not by clinging pathetically to the status quo, but by allowing it to expand and change and adapt. That's not going to happen unless the public demands it happens. And just as importantly, until there's a healthy environment for discussion and debate. I used to be much more critical of politicians, say, oh, we're lacking leadership and all that. They're a bunch of lazy bums, they just want to get reelected. But they have an unenviable task. Today, anyone who deviates from the status quo, anyone who suggests any change, gets shot down. They get crapped on mercilessly, and it's very unhealthy. We have to create this environment that allows our leaders to lead. That's going to be the first big step to change. And what I want our leaders to say when they have that opportunity is that Medicare cannot be static. It has to be a living, breathing entity, just as it was when it began. It has to grow, it has to mature, and it has to adapt to the times. If Medicare is allowed to do so, I think it will serve us well for many years to come. And hopefully, our children and our grandchildren will benefit from this program just as we have for many years. So I thank you for your attention, and I welcome any questions or comments you have. Thanks.